My indications for hip surface replacement are any patient under 65 years of age who is otherwise a candidate for total hip replacement and has adequate bone stock. As a rule of thumb, I require approximately 2/3 of the femoral head to be viable. There should be no severe acetabular deformity or dysplasia. Crow 1 and 2 dysplasia can be done routinely. All patients with previous acetabular fractures or more severe dysplasia would need custom acetabular implants. Finally, there should be no severe osteoporosis. Multiple approaches are possible. However, I prefer the posterior approach. Hip surface replacement is definitely a more difficult operation than standard hip replacement. It requires that the surgeon has a large experience with hip surgery and is dedicated to developing the special skills required for hip surface replacement over time. The most difficult aspect of this surgery is mobilizing the femur adequately to gain access to the acetabulum. A step-by-step approach has been developed to achieve this in every case, usually through a 4-inch incision. Here are some tips to get started. Pick a thin, flexible female patient with an average to small femoral head, no previous surgery, and no deformity. Use a large posterior incision. Have a large metal-metal bearing total hip replacement available as a backup, and make sure the patient is aware of this possibility. There are several theoretical considerations that will make your surgery more successful. Number 1, properly mobilize the femur. The entire capsule needs to be divided. Number 2, an adequate pocket for the femoral head needs to be made superiorly. Number 3, the femoral head needs to be prepared adequately. Inadequate preparation leads to early failure. There are several points here. First, you have to resect enough femoral head. If the lateral offset is increased, the rate of femoral neck fracture is increased. Notching is frequently emphasized. It can cause early femoral neck fracture. With the instruments that I am going to show you, this should be a rare event. Removal of cysts and proper preparation of sclerotic bone prior to cementation is absolutely mandatory. Cement against sclerotic bone does not provide any fixation. Large cysts are also a problem, as are large avascular segments in cases of osteonecrosis. The best method to deal with these has not yet been established. Currently, I am bone grafting large isolated cysts prior to cementation. Smaller cysts are used for cement fixation holes. Finally, we should not allow excess cement to be trapped under the femoral component. To be sure this does not happen, use cement immediately after mixing, provide a cement escape route, apply a small amount of cement to both surfaces, and verify that the seating level of the femoral component matches the position achieved with the trial previously.